Hello and welcome to EJC News Focus, coming this month from the European Cancer Congress in Vienna. The first presidential session featured the latest data from EUROCARE, Europe's largest population-based study on the survival of cancer patients. It now covers half of the European population. Milena Sant from Milan presented the data. I met her and asked her first what's so special about the EUROCARE data.
The project started in the late 80s, and now the database contains survival data from more than 22 million persons, more than 20 million persons, from adult and children cancer patients.
What were the key findings of EUROCARE 5?
The key findings are the great variability in survival, the great variation in survival between countries and between group of patients. For instance, elderly patients have consistently a poor survival, even taking account of the general mortality competing to cancer mortality.
Does the EUROCARE data give you the reason why?
We can speculate on some reasons. For instance, I showed that the survival is directly related to the total expenditure on health. So, a first reason of these inequalities is the differential investment in health. But in countries like UK or Denmark, the investment on health and the general income of the country, the GDP of the country, is high and is similar to that of other neighbor countries, similar and comparable, where survival is higher. So it is not only a problem of how much you invest, but also on how much you organize and you use this money. So it's a problem of for instance, centralization of cancer centers, multidisciplinary care, reducing the fragmentation of cancer services, reducing the delay from symptoms to access to specialist care.
You also said that in some cancers variation is greater than in others.
For breast cancer, colorectal cancer, the variation is more pronounced than for prostatic cancer, for instance. There is a large variation. These are the cancers with a rather good prognosis and which can benefit from screening for breast and colorectal and also from early diagnosis. Unfortunately, for poor prognosis cancers, the variation in survival is not very strong. Lung cancer, esophageal cancer, and pancreatic cancer carry a very poor prognosis in all countries and in all regions.
You also highlighted CML.
The survival of CML was dramatic, even in a short period of last study period of EUROCARE from 2000, from the beginning 2000 to 2005. There was one of the most striking increase in survival, and this was probably related to the availability of new effective treatments, specifically imatinib for chronic myeloid leukemia. This improvement did not start at the same time in all countries and was not at the same level in all countries, because in countries like in Eastern European countries where the drug was available later than in other countries, the survival increase started later.
What impact have previous analyses had?
The EUROCARE results in general have highlighted regions of low survival, regions of poor outcome where actions are needed to improve the outcome. We found that many countries were skeptical in in recognizing the problem, for instance in the UK. But actually very earlier, in early 2000, in UK some actions were implemented to improve outcome. One was the nomination of the cancer director and the adequate funding of the national cancer system to improve centralization of services and to reduce the delay in referral. Another action was the National Health Department implemented an international cancer benchmark project. They highlighted that in Denmark and in the UK, the improvement in survival, in cancer survival, which is evident in most countries, in practically in all countries, is faster in the UK and in Denmark than in other countries. So,
what do you hope will come out of this analysis?
So what I expect is that these results will be diffused and that these results will stimulate new studies and also new data from cancer registry, new and more detailed data. And actually the next round has already initiated, and the news is that for EUROCARE 6 the data call will be made together with the association of European Network of Cancer Registries, with the European Network of Cancer Registry. This will allow us to start having a cancer information system, let's say, based on data from cancer registries, from population cancer registries, similar to the SEER in the United States. So hopefully we will be able to study several indicators, several epidemiological indicators, not only survival, but also prevalence, incidence, mortality.
So the more detailed the information, the more informed the conclusions.
In the framework of the large, huge EUROCARE study, which is useful to give us the idea of the general trends in survival, we have some studies, smaller studies, the so-called high-resolution studies, in which we collect on a sample basis, we extract samples of patients, in which we collect very detailed information on stage, biomolecular characterization of the tumor, treatment, diagnostic examination made, follow-up and relapse, and so on. This high-resolution study can give us real hints on the reasons of increase in survival and can help us to discriminate, to understand whether these improvements are real or not real, and the reasons why there are so large inequalities in cancer survival.
So there's a lot more potential in this data. And with thanks to Milena Sant, that's it for this month's EJC News Focus.